Hello, everyone. Thank you for joining us. Welcome to the Avexia webinar series. Our topic for today is Pharmacogenomics, PGX, Candid Conversations between Lab Director and Pharmacist. My name is Christopher Chu. I am the Director of Marketing for Avexia Diagnostics and will be your host. Today, I have the distinct pleasure of being joined by two exciting guests, Dr. Zahara Kashi and Dr. Nathan Fuller, who will be our presenters for this webinar. Dr. Kashi has significant expertise in clinical laboratory development, quality system auditing, GMP development, project management, regulatory compliance, strategic planning, and business development. She is a highly sought clinical laboratory consultant with dozens of peer-reviewed publications and abstracts, as well as numerous invited presentations. Dr. Kashi is active in various regulatory agencies, including the American Society of Histocompatibility and Immunogenics, ASHI, College of American Pathologists, CAP, and American Association of Blood Banks, AABB, which she has served in many roles, ranging from inspecting laboratories to serving on the board of directors. Dr. Fuller was honored to be able to earn his doctorate of pharmacy in the wonderful state of Wyoming at the University of Wyoming after completing his Bachelor's of Science in microbiology there. His certification in pharmacogenomics allows him to take microscopic view of the relationship between genetics and medication response. His background is in community pharmacy and is passionate about sharing knowledge and expertise as a pharmacist to grant complete understanding and successful use of medication. Dr. Fuller currently resides in Colorado with his wife and 4 children. Without further delay, I will now turn the webinar over to Dr. Kashi.
Thank you for the introduction. Pharmacogenomics, abbreviated as PGX, is the study of how an individual's genetic makeup affects their response to drugs. The goal of PGX testing is to use this genetic information to choose the best drugs and best dosages for each individual, making treatments to be more effective and also the side effects to be significantly less. Next slide. People have differences in their DNA sequences. These differences are referred to as polymorphisms. There are different types of polymorphisms within human genes that can be in the form of either a single nucleotide polymorphism, when there is only one single nucleotide is going to be different than the rest of the population, if you will. There may be in a simple sequence length polymorphism, when the length of sequences are going to be different between individuals, or they may be implicated by the presence of what is known as insertion or deletion of genes, when some nucleotides within the genome may be either missing or have been added, if you will, to completely change the message of DNA, if you will, due to those variances. Next slide. Regardless of what type of polymorphism an individual has, this is what is leading to the drug response differences between individuals. While these differences don't necessarily impact everyone, as we all know, in medicine, 20% of patients often produce 80% of problems, meaning that a given drug may be safe and effective for more than 80% of people, but then in 20% of cases where the problems arise, the issues can be significant because of the influence of the presence of multiple genes and a variety of different variation, which would potentially be impacting a great number of individuals, despite the fact that we have 80% overall responding to a given drug. But as these genetic variances culminates in a population, sooner or later you have almost everybody impacted by a drug metabolism and the impact of these genes. Next slide. The polymorphism can affect how drugs are metabolized, and basically the drug metabolism is going to be taking they're taking place in human liver predominantly, and they are conducted, if you will, by various enzymes whose genes are predominantly expressed in liver. For example, cytochrome P450-2D6, also known as CYP2D6, is an enzyme that in humans is encoded by CYP2D6 gene that is primarily expressed in the liver, and it is responsible for the metabolism of SSRI drugs, the tricyclic antidepressants, and beta blockers, to name just a few. Polymorphism can also be impacting the drug response via impacting how the drug is transported. For example, there's a gene known as SLCO1B1 that is an influx transporter that moves drugs into the cells. Variations in this particular gene may impact the blood levels of drugs that are known to be substrates for this transporter. Examples of these include statin drugs, the angiotensin converting enzyme, the AC inhibitors, the methotrexate, or again, a few to name basically that are going to be affected by the variation in the genes that translate to these particular transporters. Polymorphism can also impact drug response by changing receptor sensitivity. For example, OPRN1, the mu1 opioid receptor, is a pharmacodynamic receptor that is known to be responsible for opioid effectiveness. There are genetic variants that would reduce the receptor's binding capacity for some of these drugs, and the examples of those would include naltrexone. The efficiency of this for treatment of alcoholism and addiction to opioid could be significantly lessened if the variation is existing in mu1 opioid receptor. Polymorphism could be also linked to disease susceptibility. Examples of those are human genes HLA, DQ2, DQ8, and in celiac disease. Lastly, there is an adverse drug reaction that could also be induced by polymorphism of different genes in human. One example of an adverse reaction is in case of Stevens-Johnson syndrome, known also abbreviated as SJS, that could be caused by a few drugs, primarily the response to penicillins, some of the anti-epileptic drugs, the carbamazepine, as well as some of the NSAID drugs that could potentially, if there is a change in a genetic makeup or a presence of certain alleles within HLA-B, which is primarily HLA-1502, B1502 allele, would put the individual at a much higher risk for developing SJS when they're going to be treated with this particular anti-epileptic drug. Next slide. So clinical, I guess the clinical significance of these, whether it's whether it's the order of the testing would be really having to be looked at and placed exactly as you would, as a clinician, you would be placing any other testing. It is an informative manner, and it could be either proactive or in a reactive manner, that you would be ordering the test based on the clinical features that are going to be expressed by the individual. For example, you may have someone who would be reacting to a drug either an early or an excessive toxicity. There may be a lack of response or requirement to just putting the patients on very high doses. Those are usually the clinical indications for every clinician to know that there may be a variance in the individual leading to the problems with drug interaction or responses to the drugs, or maybe a history of multiple drug intolerance when there is a no evidence for a true allergy in an individual with the conditions that we want to probably consider as a potentially a reactive or again as a proactive amendment to order this test to understand how your patient respond to the drug. It may be also an indication based where there is a lifelong history of, let's say, depression in an individual and the lack of good response to the antidepressants. Potentially these genes and variation of these genes can be explained very well by why the individual is not responding and why there is an ongoing anxiety depression going on. Example of that is a CYP2D6 when the individual is has a gene variant that leads to this variant for the individual to not metabolize the drug appropriately and leading to an accumulation of this drug in the system causing toxicity per se, and really the patient not benefiting from any of these drugs. Or the recyclic C19 is another prime example that individual may not be again metabolizing the drugs well enough, either stays in the system too long or there's not enough of it leading to the clinician adding the dosage earlier. Next slide. So the genotyping in general is an assessment of inter-individual variability that most drugs are essentially going to be accounted for. However, please keep in mind that not all drugs are going to be accounted by necessarily only one variable gene or one variance. And that is why it is imperative that this test is ordered and administered, if you will, and interpreted by a healthcare professional who really understands not only the drug and medicine, but also the genetic implications that are due to these variances, in particular a pharmacist who understands both sides of this equation, if you will. So consequently, it is imperative that the patient would be needing to receive a pre-test and a post-test counseling, if you will, and be advised for what the reason is for the test, what the limitations of these tests are, and be able to receive, after the test is complete, what the test means and what are some of the current implications of this test, and also limitations of the information provided by this test. And lastly, more importantly, for the patient to be on a medicine that is actually going to be impacting their health appropriately. With that, I'd like to introduce Dr. Nathan Fuller, who is indeed a pharmacist and is quite savvy with genetic information on human beings, for him to present his case studies of some of his patients. Thank you very much.
Thank you, Dr. Kashi, for that great introduction and science behind pharmacogenomics. I wanted to transition into a case study. Excited to present a recent example of how PGX is used in practice. So my patient RA is a 59-year-old who was recently hospitalized. RA underwent a procedure for stent placement within his coronary artery. Medications commonly prescribed following stent placement include low-dose aspirin and another antiplatelet agent like clopidogrel. So RA presented to the pharmacy for his new medication, clopidogrel, which became the medication of focus relating to the PGX intervention. RA's medical history was significant for hyperlipidemia, hypertension, angina, and benign prostatic hyperplasia. His medication list included rosuvastatin, nitroglycerin, isosorbide, aspirin, clopidogrel, hydrochlorothiazide, metoprolol tartrate, and tamsulosin. With any new medication that comes to the pharmacy, we offer counseling to clear up questions about the new medication, how to take the medication, discuss drug interactions, and how to monitor for and manage potential side effects. Now, through counseling RA, I was able to learn that he was of Filipino descent and that he takes omeprazole for heartburn over the counter. I explained that both genetics and a potential drug interaction with omeprazole may make his new medication clopidogrel less effective. Both pathways are factors that influence how clopidogrel is metabolized. I asked RA where his procedure was and which hospital his provider was at. After confirming the locations, I knew that the hospital network routinely performs PGX testing for their cardiac patients. I contacted the cardiac provider and recommended that they took another look at the PGX results to confirm the evidence-based drug selection, considering the factors discussed with RA. As Dr. Kashi mentioned, when looking at genes and genotyping, we are considering how the polymorphisms affect the function of genes. As in this example, most PGX reports organize the important information into 3 categories, including the gene, genotype, and phenotype. The gene identifies the coding information for the specific enzyme. In this case, I use the common liver enzyme CYP2C19 that metabolizes many medications. The genotype lists the 2 star alleles of focus. In this example, we are given star 2, star 2. The genotype allows us to assign a phenotype based on the expected activity of the enzyme. This enzyme would be expected to have reduced activity based on the homozygous reduced activity seen with star 2. Usually, normal phenotypes are reported with star 1 on the report. Now, using the results from the previous slide, this is an example of a recommendation based on RA's PGX results. Looking at RA's new medication clopidogrel, we have to consider that clopidogrel is a prodrug. A prodrug is a medication that needs to be metabolized into its active form to produce an effect. This active form needs to reach adequate levels in order to produce a therapeutic effect. Now, on the previous slide, we saw that the genotype star 2 for CYP2C19 gives us a phenotype of 4 metabolizer. If the enzyme CYP2C19 has little to no activity, it cannot metabolize clopidogrel into its active form for the expected antiplatelet effect to occur. We use the high-quality evidence in the guidelines provided by CPIC to arrive at the recommendation to avoid clopidogrel if possible. We'd want to consider alternative options such as prasugrel or ticagrelor at standard dosing as long as there are no contraindications. These alternatives do not go through the same metabolism pathway to platelet effects. As a result of considering RA's PGX data, the prescriber sent a new prescription for prasugrel 10 milligrams. This prescription replaced the potentially ineffective medication clopidogrel based on guideline level evidence. I did receive a call from RA's wife later on, letting me know that she thought that the recommendation may have saved her husband's life. Pharmacists, as a part of the healthcare team, are poised to make interventions like this every day. helping patients to receive personalized care, improving safe and effective use of medications. That ends the case study. Thanks so much for tuning in. We hope that this was helpful and enlightening to you. And thank you so much for joining.
For any questions or issues you may have, please contact Avexia Diagnostics by email at info@avexiadiagnostics.com or by phone 5 days a week at extended hours, 8 a.m. to 8 p.m. Eastern Time at 888-852-2723. Thank you, Dr. Kashi and Dr. Fuller, for this informative presentation. Thank you all again for joining us. Until next time, from everyone at Avexia Diagnostics and Kashi Clinical Laboratories, stay healthy, stay safe, and we wish you all the best on your pathway to wellness.